At this point, I'd like to introduce our second speaker, Brent Delvaux, who is with TRG, and he's going to talk to us about the changing landscape in the drug and benefits sphere. In his bio, it says Brent, like most leaders in business, is very competitive, and he's a competitor that also puts respect and reputation before competitiveness. When I first talked with Brent, he told me he had 21 years in the group benefit business. In fact, his whole professional career has been in group benefits, first with a large insurer, and in the last few years with TRG. He lives in Vancouver, obviously. He's got 2 kids, a son 16 years old and a daughter 14, so I'm sure that's a handful for him. And while he's been an active athlete in rugby and hockey, he's a coach primarily now, and his passion of golf is getting a bit more attention than it once did. So anyway, I'd like you to join me in welcoming Brent to speak to us.
Okay, thanks, Roy. I'm very pleased to be speaking with everybody today, and I've learned a lot putting together this presentation on the evolving drug management landscape. Hopefully you'll learn something today as well. I'm going to focus on 3 areas. I'm going to talk about why the drug costs are increasing, how the industry is reacting, and how to ensure plan sustainability, okay? To give you an analogy of what's going on in our industry right now, when you're watching a movie and an impending disaster is going to happen or something's going to happen, you see the animals get agitated, birds are flying out of the city. Well, that's what's going on in the industry right now. The provinces, the governments are getting agitated with what's going on in the drug landscape. The insurance companies are getting agitated because we know there's a storm coming. We know there's a problem coming on the drug management landscape. So we've got to see what we can do about it. When I talk about where the costs are coming from, I'm also going to talk a little bit about generics, because I find generics, it's a bit confusing in the marketplace when people think about generics. There's a lack of understanding on it. And whenever I'm meeting with a new client, inevitably one of the questions that comes up is about biologics. So I'm going to try to touch a bit about this and try to take away some of the mystery of biologics. This is like an eye test for you. Where are the costs coming from? So everyone knows prescription drugs in general have been increasing 9 to 12% a year, so we know that. But it's interesting to look at this slide is there's been a huge increase. What jumps out to you right away is specialty drugs, drugs that cost over $5,000 a year. They've increased 325% since 2005. But when you dissect this a little bit further and you look at it, it's amazing that acute drugs, which are short-term medications, things like amoxicillin, Tylenol-3, things that you would just be short-term in nature, it's the same amount of dollar spend as these specialty drugs. But when you look at the average cost per claimant, what a tremendous difference. Average cost per claimant based on this data is $15,000 for these specialty drugs. What's driving the costs? Well, fortunately, we've got some downward pressure that's going on in the marketplace right now. There's a patent cliff. I got a slide on that coming up. So we're seeing some of these blockbuster drugs coming off a patent. And when they come off a patent, right away, generics introduced to the industry. And also the provincial governments, all of you have probably been reading about it, or you've been hearing about it from TRG, how the provinces have been introducing new legislation, reducing the cost of generics. But we can't be complacent because there's some upward pressure as well. There's high-cost drugs entering the marketplace all the time. We are getting older. I'm getting older, I know that. And the demographics in general are getting older. There's increased incidence of chronic conditions, lack of consumerism, and open formularies. All of these things are adding to the increase in average costs of drugs. Generics are always very confusing, and to be honest with you, while I was working on this presentation, I learned a lot about generics. So I thought, why don't we give you the basic definition as provided by the Food and Drug Administration. A generic drug is identical or bioequivalent to a brand name drug in dosage form, safety, strength, route of administration, so that means how you take it, quality, performance characteristics, and intended use. The key word there is identical. What does bioequivalence mean? Well, bioequivalence of a generic drug means that the active ingredient is absorbed into the body at the same rate and amount as the brand name product. It ensures that the delivery of that gets the same therapeutic effect as the brown counterpart and can be safely substituted. And this is where some of the confusion comes in. When I meet with clients and talk to them about it, a lot of people see when a generic comes to the marketplace, they almost consider it a therapeutic substitution. But the generic drugs associated with that specific brand that comes off a patent. So in 2010, a blockbuster drug called Lipitor, which was for cholesterol, it came off a patent. Lipitor represented about 5% of overall claims in the marketplace. The insurance industry expected that we'd see a large drop in cholesterol drugs because the generic came out quickly. But what happened? His doctors started prescribing another brand called Crestor. And people were assuming, I have a generic substitution plan, well, I'm sure I'll get the generic. But what they didn't realize is there was no generic for Crestor. There's a therapeutic substitution, but not a specific generic. So even if you had a generic substitution plan, if your doctor if you had a generic substitution plan and your doctor prescribed you Crestor, that's what you got paid for under your drug plan. Let's do a little bit of a test here. If I asked you, true or false, brand names work better than generics, what would your answer be? Well, the answer is false. If I said brand names are safer than generics, what would you say, true or false? False. How about generics use less quality ingredients than brands? True or false? It's the same person answering, I love that. Brand name drugs are better quality than generics. True or false? False. So now you don't have to answer this so loud. Now think about your own purchasing. If you or one of your family member has a fever tonight, you come home, your spouse says, so-and-so's got a fever, can you go pick up some medicine? When you go to the pharmacy, do you buy Tylenol? Or would you purchase acetaminophen, which is the generic for Tylenol? If you have a sports injury and you need an anti-inflammatory, do you purchase ibuprofen or Advil? Because the Advil and the Tylenol are much more expensive. And if you look at it, they're the exact generic equivalent. You look at the ingredients, they're the exact same. But we're in love with our brands. And to be honest with you, I went home, I found a lot of ibuprofen, but I also found a lot of Tylenol. Now, we're a little bit different because my wife will buy the Tylenol in bulk, so we end up throwing it out anyway because we'll never use that many. So there's even more waste going on in my family. But it's amazing when you look to talk to people, they say, take some Advil. You've got a swelling there. Make sure you get some Advil right away. I mentioned this patent expiry. This is really, again, another eye test. But what I wanted to point out to you is 2012 is a big year. There's a lot of drugs coming off a patent. Two of the biggest ones are Nexium, which is a gastrointestinal drug, and Crestor, which again is this cholesterol drug. Now, Crestor already has a generic in the marketplace. And these drugs represent about 10% of the overall drug spend going on right now. So we're a little bit excited in the industry right now. Are we going to see costs come down? Or is the same thing going to happen when Lipitor came off a patent? Is another brand going to get substituted instead? And also point out through here, there are some other drugs that are coming off in 2013 and 2014, but they're not going to have the same impact as 2012 is going to have. Biologics. We actually, Queenie and I wrote a blog on biologics as well. But again, I thought to take away some of the mystery, I'd give you the definition. Biologic drugs are drugs created from a living organism or its products and can be composed of sugars, proteins, nucleic acid, complex combination of these substances, or living entities such as cells as tissues. The molecular structure of a biologic is so complex, they will never be a generic because it'll never be bioequivalent. We might see some subsequent entry biologics that will mirror what's going on with the current biologic, but you'll never see a generic. And costs can exceed up to $500,000 a year. So that drug in question that's about $500,000 a year is a drug called Solaris, and I've got some information on it that in a discussion I had with Great West Life. The treatment for Solaris, it's the treatment of a rare blood disorder, which is difficult to diagnose, often on a deathbed, but once detected, the treatment is 100% known to work. It's a lifetime of treatment. Every 14 days you need an infusion. Not every 13 days, not every 15 days. Every 14 days you need an infusion, and it adds up to $500,000 a year annually. There are currently 56 people on Solaris in Canada, and another approximate 20 individuals that need the drug but don't have access. Not all provincial plans cover Solaris. In fact, British Columbia is one of the provinces that don't. Now, Great-West Lifehold's indicated to me that they currently have 9 claimants on this drug, and this represents about 0.2% of their overall drug spend. But they also said, and interesting data, is that if just 25% of people using Crestor switch to the generic version of Lipitor, it would represent the same savings as the amount they're spending on Solaris right now. This slide shows you how much generics, or how much biologics have been increasing in the marketplace. They're over 14% of the national spend right now. And based on some information I received from Health Canada, there's over 100 biologics right now in phase 3 clinical trials. And phase 3 clinical trials mean it's the last phase before they're released to the marketplace. So not only are we seeing new biologics come to the marketplace, we're seeing the route of administration change among these biologics. So in 2011, Health Canada approved the first oral medication for multiple sclerosis, MS. The drug's name is Gilenya. So prior to this, MS patients required regular injections. So now they've developed something in a pill form. Isn't that great? Wouldn't you rather take a pill than have to take regular injections? The problem is that Gilenya costs $35,000 a year, and the next closest drug in this class, Rebif, costs around $24,000 a year. So it's $11,000 more. So no one's arguing that these drugs aren't necessary, that they're incredible, life-sustaining drugs, but who's going to pay for them? That's the question. But worst of all, what if you had one of these diseases, or a loved one, and you knew there was a drug available, but you couldn't afford it? Now I'm going to get into tell you how the industry is reacting. Talk about legislative changes, we'll talk about the pharmaceutical industry, and we'll also deal with what the insurance companies are doing. At the last health symposium, we gave you a slide talking about the various provinces are doing, and it's increased even more, and I'd say almost every province now has done some sort of legislative reform on generics, trying to reduce the costs. So I'm not going to get into that, we can do a whole presentation on that. But a couple of things have just happened recently. So as of April 1st, BC is scrapping their pharmacy deal that they signed. They weren't saving enough money. So the slide says April 24th, but that was the article that we were sourcing, showing that their savings was actually $91 million less than what they expected. So they didn't get aggressive enough with their pharmacy deal. Ontario, which is one of the most aggressive provinces in legislating some of these generic plans, they've announced in their most recent budget that they're doing a further reduction on the top 10 prescribed generics from 25% to 20% of brand costs. Some provinces have given pharmacists additional prescribing rights. So what used to happen historically was that you might get prescribed a brand by the doctor, you go to the pharmacist, many times they would substitute a generic for you. So what we found out was that a lot of reasons, maybe not the only reason, but a lot of reasons the pharmacists were substituting generic is they were getting rebates from the generic manufacturers. Some provinces have taken these rebates away. The provinces are pushing down the cost of generics. So can we see a point where the pharmacist actually substitutes a generic for a brand? If your plan isn't set up to capture that, then it might be something you see. Ontario passed legislation last year to allow remote dispensing drug machines. This is very interesting. If you're a large employer, you can have it in your building. Based on a Globe and Mail article that I read, it said that these machines can dispense up to 2,500 different types of drugs. You stick your prescription in, then your drug card. If you owe any money, it'll take your Visa, it'll take your debit card, and you get your prescription dispensed to you. Some of these new high-cost drugs aren't being added to provincial formularies. So who picks up the cost? The private insurance industry does. Hospitalization rates are decreasing. We're all seeing that. A lot more day surgeries. Well, according to the Canada Health Act, if you're dispensed and given a drug in the hospital, you can't be charged for it. So with hospital rates decreasing, a lot of times if you've had any day surgery, you get a prescription on the way out. Go get it filled. Here you go. So now that cost gets shifted to the private plans. Hospitals are even teaching patients how to administer specialty drugs. There's infusion clinics popping up. They're big in Ontario, and I think there's nine or 11 or so here in British Columbia. So you go to these clinics to get your medication, whether it's Remicade, but you pay the cost of it. And because it's an infusion clinic and not a hospital, it's not covered under the Canadian Health Act. What's the pharmaceutical industry doing? I should say we were afraid of generics. Well, the brand companies want to keep it that way. They are very good at advertising. My brother-in-law is a doctor, and he told me that more and more patients are coming in asking for specific drugs. And he's more than happy to oblige if he thinks it's the right drug. Pharmaceutical reps are calling on doctors all the time. Those of us that are golf fans, we've known that Phil Mickelson, who's one of the best golfers in the world, was diagnosed with a serious form of arthritis a couple of years ago. And they talked about how it might ruin his career. Lo and behold, he gets some Enbrel, and now he's one of their spokespersons. And you'll see if you listen to him talk, he is 100% cured in his mind as long as he takes this drug. Very powerful messaging. Just as an aside, does everybody understand the differences between US drug advertising and Canadian drug advertising? In the US, you need to give equal amount of time to talk about the negative side effects of the drugs. So you see a drug commercial in the US, they'll tell you what the drugs are about, and they might say, you may lose your hair, you might go blind. If you're about to die, call the doctor. Right? And it always seems so funny, but that's how the advertising rules in the US work. In Canada, it's quite different. You can advertise in two different ways. The first way is you can say what the drug's for, but you can't say the drug name. So you can say, do you have gastrointestinal or acid reflux syndrome? Go see your doctor. But you can't name the drug on that advertising. Or you can name the drug, but you can't say what it's for. So that's where we see our great Viagra commercials, right? Sorry, boys, Murray couldn't make golf today, so you had to play with this guy. Then you see Murray in the kitchen like this saying, and then they say Viagra. They never mention once that it's erectile dysfunction drugs. Something that's interesting that's happening in the US right now, if it happens in the US and works, we're going to see it in Canada, something called drug coupons. So in the US right now, the brand manufacturers are letting you go on and print off a coupon to get reimbursed for part of your cost if you get one of their drugs. So if you think about it, it might be cheaper for an employee to get the brand name and get reimbursed as opposed to taking the generic. Even if you have a copay. It's interesting that I went on the internet to take a look at it. You could get them for just even over-the-counter prescription drugs. So we're going to be watching this to see how this affects the industry. What's the insurance companies doing? I'm actually quite proud of the way the insurance industry has reacted to this. I've gone to a lot of seminars, a lot of meetings, and the insurance industry isn't saying, let's cut out biologics, we can't afford them. They're saying, no, we want to cover those drugs because those are the right things to do, but we need to get people moving towards generics. They're trying to lower the cost of providing the drug, but not removing the drug. Some other things that they're doing, we're seeing, and I'm not going to mention what the companies are. All your TRG advisors have the slides on this, so they can go through these things with you if you want to get into more deeper discussion. But enhanced generic substitution. So right now, the doctor just writes no substitution on the prescription, and then which happens more often than not, and then you automatically get reimbursed the brand. Enhanced generic substitution is a doctor would have to fill out a form explaining exactly why you can't take that generic. Health case management, having an employee advocates manage a claim from start to finish. Provincial integration, making sure you integrate with pharmacare. A prior authorization, you have to get authorized for certain drugs to make sure they're being dispensed for the right thing. Therapeutic-based drug plan designs coming to the marketplace. So, if you are being prescribed a Crestor before it had this generic, a therapeutic generic substitution would mean you'd have to try the Lipitor generic first. Or pharmacy partnerships, trying to get a better deal with certain pharmacies. Other useful tools, Roy was talking about TriFit, who's one of our sponsors today. And we're big proponents at TRG on health and wellness. We think it's a great thing to have in your firm. And TriFoot's a great company. In fact, we use them as well for our employees. But when you're trying to put together a health and wellness program for your company, it's important to see where the actual drug costs are coming for your employees. If you start putting a strategy together because you see a high amount of diabetic claims, but you don't know that most of your diabetic claims are coming from dependents, how can you put a proper workplace health and wellness program in place? Drug analysis tools. One of the suppliers here today has a great tool where they'll take your actual data, run it in a simulation to tell you how much you would save if you went to a certain drug plan, as opposed to just doing actuarial estimates. A drug smartphone app, which tells an employee, reminds them when they have to take their medication. Other useful tools. Wouldn't it be great if there was an app which could tell you where you can go to, which pharmacy had the lowest dispensing fee and how close it was to you? We have GPS in these smartphones. Wouldn't it be great if we had that app available? Or, I know there's an insurance company trying to work on this right now, creating an app for employees so when they're in their doctor's office and the doctor says, I'm prescribing this to you, you can put the name right into that app. It tells you what your plan would pay and whether there's a substitution for it that would get you full reimbursement. Wouldn't that improve consumerism? I wanted to touch upon pooling stop loss more because it's very topical right now. And there was a great article in the Financial Post yesterday as well. Basically, if you're not sure what pooling is, there's a certain part of your plan's protected, your healthcare plan is protected. You'll only have to pay for a certain amount of claims within your drug experience when setting rates for the following year, and the insurance company will absorb the rest above that amount. But you're paying a premium for that. It's built into your rates right now. You probably know what it is if you're self-insured, but if you're fully insured, it's there. It's part of your premium cost. Costs are going up, pooling levels are increasing, more because of these larger biologics. Now there's a new industry pooling plan that's come together. It's where all 24 insurance companies that are part of the Canadian Life and Health Insurance Association have come together. And you're probably thinking, is there 24 insurance companies? I said, I couldn't mention them all either, but all 24 companies have come together as an agreement. There's a lot of confusion around this agreement, or a little bit in my mind still. It comes into place January 1, 2013. But what worries me a little bit is it's only applicable to fully insured plans. So if you're a self-insured ASO, or you're retention accounting, you're not included in this pooling arrangement. So does that change your strategy? Third part of my section here, I'm going to talk about what can you do to ensure plan sustainability. I'm not going to give you a magic bullet. I've always been a big proponent that every customer is different. You're all different sizes, you're in different industries, you're in different growth cycles, so there's not one strategy that's going to work for you. And in fact, even among the TRG associates, we all don't agree with a certain strategy. So the first thing you should be doing is having that discussion with your TRG advisor. If you're a TRG client, talk to your TRG advisor. If you're not a TRG client, come talk to me. But you want to have that conversation. And your decision might be status quo, and that's okay as long as it's an informed decision. Maybe put it on paper. If you're not the main decision maker in your group, involve your decision makers. Make sure they're aware of what's going on in our industry. Even if you have a collective agreement, involve the union. I've sat on both sides of the table. They just want to, unions in general just want to make sure that they're not losing some coverage. There's a lack of understanding with them as well, just like there is with employees. A drug card. A drug card is a great management tool to have. In fact, a lot of insurance companies aren't even enhancing their reimbursement platform because it's such a dwindling amount of clients that are staying on that if you really want to get and have the right up-to-date plan designs, you have to do it with a drug card anyway. Protection against two-tiered pharmacy markups. Most people are aware that there's a dispensing fee. It shows it on your drug receipt. Some pharmacies charge more than others. And then you see the cost of the drug. But they don't understand that there's a markup associated with that. And that's very important because you can limit the markup on an electronic platform, but for the most part you can't on a reimbursement platform. I read a great article called An End to the Blank Checks, Getting More Value out of Employee Drug Plans. The article is by Helen Stevenson, President and CEO of the Reformulary Group, former Assistant Deputy Health Minister in Ontario. And there's a lot of valuable information in this paper, but two things stood out to me. She provided an example of a specialty drug that was dispensed at Pharmacy A and the same drug dispensed at Pharmacy B, but there was a 50% variance in the cost. Pharmacy B was 50% higher in what they were charging. The dollar amount of that claim was $2,500 for the exact same drug. She also found evidence of pharmacists trying to change the dispense medications for chronic maintenance drugs more often than 90 days. Sometimes saying it's because of safety issues, we want to dispense it every 30 days. So what that does is get you charged 3 different dispensing fees. So if it sounds like I'm picking on the pharmacists, I'm really not. The governments have really come in and changed their whole model. They put a lot of pressure on their revenue model. So they're scrambling like everyone else to try to stay in business. We just need to find ways to make sure that you're not overpaying for something. Deferred drug card. A lot of reasons you won't have a drug card in place is because there's a utilization increase. That it'll range from some carriers saying it won't cost you anything to add a drug card to other carriers saying it will cost as much as 20%. Even the TRG associates, we all differ a little bit on what we think that real number is. I think it's somewhere in the middle. I'm still a bit of a believer in the shoebox effect. I think the shoebox effect, what that means is you put drugs in a shoebox and you submit them once they get to a higher amount. But with online claims, I think that's really reducing. But there's also something called point of purchase convenience. So what that is that whenever you don't have to physically pay for something out of your pocket, your buying decision changes. So you go see your doctor, you have a stuffed up nose, you've had a nasal infection before, you say, I think I have a nasal infection. The doctor's saying, well, I don't want to give you any antibiotics if you don't really need them. But I think you'll be better, but here's a prescription. If you're not better in 5 days, get this filled. Every time you walked out of your doctor's office, what do you see? You have a pharmacist. If you're not paying for anything out of your pocket, chances are you might as well get it reimbursed at that point and then use it if you need it, as opposed to getting it filled after if you need it. They don't think it's your cost. They think it's just the insurance company that loses in the end. Where a deferred drug card, what that does is that you get a drug card, but you physically have to pay for the drug at the point of purchase. And then you're reimbursed once a threshold has been hit. Employee engagement. Employees need to understand how a benefit plan is funded. They really do. And I do a lot of employee meetings. But you, as clients, you understand your employee population a lot better than we do. I'm a big proponent of face-to-face meetings, lunch and learns, employee meetings, trying to get the message out. But it's really hard to get the message out that you're paying for these costs. And it's something that you need to continue to communicate. We had a social media presentation in our office yesterday, and we were showing some examples of employers tweeting out things to their employees. So maybe taking advantage of social media to get the message out. A lot of times the only real way to change behavior is through the pocketbook. Employees have to see that, actually physically pay a cost. So I talked about why drug costs are increasing, how the industry is reacting, and what you can do, some little tools you can do to ensure plan sustainability. Got one more slide. There's an author, Karen Lamb. I love this quote. A year from now, you may wish you had started today. Very apropos. So thank you very much for listening today. Hopefully I haven't taken up too much of your time. Are there any questions?
No, I just wanted to let you know on a couple of things. The coupons have landed on our shores already. There's radio advertising, there's website stuff, so we've got clients that are telling us about that impact already hitting.
Good to know.
And the other thing I wanted to mention is the first kiosk has also landed and is being piloted in the Sun Life head office in Waterloo. So that's
Excellent.
Testing that out as well.
Yeah, it'll be interesting to see how those new kiosks work out.
Thanks. Hi. Thanks. That was very informative. I do have a comment and a question going back to your discussion about generic drugs. So actually, we have had some contrary information, and that is that while the active ingredients in many generic drugs are absolutely identical, and the quality of the other ingredients is also very high, that often what is the difference is the filler, which is, I guess, what binds the active ingredient together, and the coating. And sometimes that makes a difference as to how that drug is metabolized in that individual's system. So my question would be, are there different manufacturing sites for generic drugs? And I mean, could one pharmacy, for example, have generic drugs that are manufactured from several different sites? And so they may have a different response for the individual that's taking them.
That's a great question, because I mentioned my brother-in-law is a doctor before, and if you ask, if my brother-in-law was here, he'd tell you that generics are no good. He would never prescribe a generic. So there's a lot of confusion in the marketplace. And you're right, there are some fillers that may affect with the generic, but there's also some brands that may not work with certain individuals. It's about testing the drug. And if there is a generic that doesn't work for you, the insurance companies will pay for that. They just want the doctor to explain what is it about that drug that doesn't work for you. And it's interesting also to know that some of the brand manufacturers also have generic products. So it's actually the same pill, just marketed under a generic. So it's the exact same drug. So there is that confusion in the marketplace, and you're so right. And I know I'm not an expert at it. That's why I wanted to research these definitions, because that's what you'll hear. They're not the same. The fillers aren't as good. But that's not necessarily true. The amount of the population that those won't work for is very small. Absolutely they won't, but just like certain brands won't work for individuals. It's just about finding the right drug.
So when we're speaking with our employees then, and certainly one of the things that I do is talk to the unions, and we're discussing their benefit programs as part of their collective agreements, we want to be promoting these options when we're talking about benefits, but we also want to be, I suppose, allowing them the understanding that should this not work for a particular individual, their physician just prescribes the brand name. Is that correct?
It's correct, and I'm sure
Okay.
if you asked any of the insurance companies here, that's how it works, unless you had a mandatory generic substitution plan, but a lot of plans aren't set up that way.
Okay.
So, but it really comes down to, you need to believe in that, and you know, a 30-minute presentation may not change your mind on that, but you need to believe in that. But again, looking at ourselves, like, I've got Tylenol at home. Why am I paying extra for something that's the same? So it's just the communication in the marketplace. There's a lot of confusion. That's a great question.
Okay, thanks.